Hello and welcome to the Introduction to Safewards talk-down intervention. This intervention is based on the model portrayed in the poster behind me. This poster was used in clinical inpatient settings during the Safewards trial. This model is based on research by our team at King's College and from work by colleagues at the University of Manchester, and represents a synthesis of this work and consultation with nurse trainers to ensure relevance to nursing practice. De-escalation is an important skill for inpatient nurses and is often the first and most important response in the prevention and management of violence. Research on aggression has shown that unqualified nursing staff and student nurses are the groups most vulnerable to being assaulted on the wards. As such, we suggest that training in this intervention will most benefit these staff. But there may still be some benefit for all staff, as other than the model you see here, there exist no systematic descriptions as to what exactly de-escalation is, and so there can be great variance in the quality of training in this area. This model portrays de-escalation as a process, as seen in the middle portion of the diagram, flanked by the additional vital factors, self-control and empathy. The first stage in the de-escalation process is delimiting. By this we mean making the environment safe for everyone involved and encouraging a cooperative atmosphere. This can include activating alarm systems to attract aid, getting other patients out of the area and maintaining a safe distance. The next stage is to clarify, finding out why the patient is agitated, offering to help if appropriate and sorting out any confusion. High emotions can make people irrational, so helping orient the patient to the moment and reminding them of your existing relationship can be useful tools to help them calm down. The final stage is to resolve, to reach an agreeable compromise with the patient and find a way of dealing with their complaint that satisfies them. Be as flexible as possible and apologise where you can. This model should not be used without regard to the other vital components. Self-control is important in managing the emotions of others. We should not allow anxiety or frustration we may feel in the situation to be communicated. Most of us are not Zen monks though, and for us the most important trick is to act the part. If you act calm and confident, people around you will assume you feel this way and will respond accordingly. Remember, if you take care of delimiting the situation, you'll have your team with you and be in a safe space. Plenty to feel confident about. While the expression of anxiety should be avoided, the expression of empathy and respect should be heightened. Show interest, concern and understanding. Validate appropriate emotions and avoid trivialising reactions. Any perception of disrespect or condescension on your part will only unsettle the situation further. In order to communicate these things, you genuinely have to engage with your patient and try to think, if this was you, yourself in distress, how would you like professionals to react to you? Through proper regard to all components described in the talk-down process, we believe this is an accessible and useful tool for staff and students working in mental health. Although there is no replacement for your own skills and knowledge of your patients, the talk-down model provides a good basis for people more new to de-escalation and a framework of best evidence practiced for established nurses.